to do well by the metric of case doubling time. We've talked about that on prior calls. We are looking for at least nothing shorter than a 7-day doubling time to give us sort of an indicator of how fast the epidemic is growing. We are now at 16 days to double, which is lengthening a little bit over the last couple of weeks. The median age of cases is 42 years old. I know that there's a common perception that this is an illness that only affects the elderly, but that is certainly not the case. While the elderly and people with underlying health conditions are at significantly higher risk for severe disease, it's important to note that our median age of cases is 42 years old. 17% of all cases are people in their 20s, and 20% are between the ages of 30 and 39. We are unfortunately at a new total of 899 deaths in Minnesota. That's 47 Minnesotans having passed away from COVID-19 over the holiday weekend. 18 of those deaths were reported yesterday. Of the 18, 10 were in Hennepin County, 3 in Dakota, 1 each in Chippewa, Clay, Goodhue, Nicollet, and Ramsey. This total includes 1 person above the age of 100, 7 in their 90s, 5 in their 80s, 1 in their 70s, 3 in their 60s, and 1 person in their 40s. Again, just reinforcing the fact that while risk is certainly elevated for the elderly and those with underlying health conditions, and especially the combination of the two, we do see severe disease and even death among younger people, and occasionally some without any known pre-existing conditions. So this remains a great concern to the overall community in Minnesota. 15 of yesterday's 18 deaths occurred among residents of long-term care facilities. From a hospitalization standpoint, there are currently 570 patients in the hospital, 258 of those in long-term care. And if you look at the data over the long holiday weekend, you see some fluctuation up and down in terms of numbers of people in the hospital, some days with significant increases, other days with decreases. But hospitalization in the ICU units has continued and has increased by a pretty significant degree. And I think Chris Erzman's going to speak to that a little bit more in just a moment. In terms of some additional information to share with you today, our testing volume continues to grow quite nicely. We had even almost over 5,800 cases, or tests rather, produced by all the labs reporting yesterday on holiday Monday, which is quite a large number for that day. Mondays and Tuesdays, as you probably recall, tend to be the lowest numbers. But over that long holiday weekend, we saw over almost 8,500 tests on Friday, over 6,000 on Saturday, and over 5,800 on, I should have said 8,400 on Saturday, almost 6,100 on Sunday, and over 5,800 on Monday. So really strong laboratory data from the long weekend. And as you recall, a significant part of that was the free testing that was opened up at 6 National Guard Armory locations across the state throughout the holiday weekend. And we are just extremely grateful to the Guard for their extraordinary work in helping to set those up with very short notice and staffing them. It was an incredibly busy weekend. The Guard provided very close to 10,000 site tests at these 6 sites. We had been thinking that the goal could be as high as 6,600. That's what we had sort of planned for on the top end. So the fact that what actually happened was 150% of that goal, that is really something. And a lot of people scrambled to get more supplies to the testing sites, it was very clear to us that the public turnout at these sites really does make it clear that there is a great interest in testing and a need for methods of getting testing out to the public in ways that make it accessible and easy for them to get to. We don't yet have a lot of data of the results of this testing, but in addition to testing symptomatic people, this was a no-barrier kind of testing pilot, if you will, where even people without symptoms were given tests, and we thought that would be one way of getting some kind of really preliminary kind of surveillance testing of a sort to help us get a picture of where there might be greater and lesser concentrations of positivity rates among these 6 sites. Chris might have more comment there as well. So this was clearly a very, very successful initiative and came with a lot of really hard work from the Guard and others. So we're going to harvest the lessons learned, see what data this provides to us, and we'll be communicating in the coming days about how it is that we intend to do more of this kind of mobile community-based testing around the state. I'd also like to comment on a couple of things that came up in questions last week. There was a question about whether Minnesota's health plans would be extending the agreement that they had previously reached with the Departments of Commerce and Health to waive copays. That they had been required by federal law, as you may recall, to cover testing without cost sharing, but they had also agreed to waive copays for COVID hospitalizations, which originally was to expire on June 1st. The health plans nearly all of the health plans have agreed to extend waiving those copays through September 30th. Another piece of news to share for today, the health department is announcing today, I believe that this is just going up on our website now, that we have awarded $97.6 million in emergency healthcare grants to nearly 360 provider organizations across Minnesota to support their preparation and response to the COVID-19 pandemic. These healthcare response grantees include a wide range of healthcare providers, from primary care clinics and long-term care facilities to hospitals and health systems and first responders. So about half of the funds went to this variety of organizations for additional staffing costs, with the next largest share of the funds going for supplies, including for their purchase of personal protective equipment, which, as you might recall, has continued to be an important strategy. In addition to the state's PPE reserves, we have encouraged providers to be using their usual supply chains to get whatever supplies they can get through their typical supply chains. And so some of this money is to assist them with those costs. In addition, providers can use this grant money to establish temporary sites to provide testing or treatment services, to expand the number of beds available for COVID-19 treatment, to isolate affected patients or staff, and to support emergency transportation. Grants can also fund some temporary information technology support to support triage screening and telemedicine, which we have seen growing very significantly with this pandemic. With this round of funding, we prioritized funding assisted living facilities, healthcare systems, hospitals, emergency medical transport, and primary care clinics. The goal is to support these providers with caring for COVID-19 patients and preparing for the ongoing rise in cases that we are still seeing and expect to continue to see increasing in the coming weeks. We also prioritized funding smaller providers, both in the metro and in greater Minnesota, in recognition of the fact that some of the larger systems also are benefiting from federal funding. We have notified all of the providers who've been awarded grants, and you can see the full list of grantees on the MDH website. There is a healthcare response grant page there on the MDH web. In addition to the grants that we're just announcing today, there are some funds left in this fund. In March, the legislature passed an appropriation authorizing $200 million in state funds to invest in this grant program. And there is still some money left in this fund, and we have set this up to have the money kind of be granted in waves, if you will, to allow for our ability to fund some needs that might emerge later in the pandemic's evolution here in Minnesota. And this application process is an ongoing one. The application process remains open and will until all funds have been spent. We do encourage organizations to submit their applications as soon as they have identified a need and as soon as they can. We do kind of package them up and make some award decisions as we have today in waves. So there will be further grant awards announced in coming weeks as well. We just, again, want to thank the legislature for their proactive action in making this funding for healthcare providers, including long-term care, available for us to work with our communities around the state. This, what I've just talked about, is really the second type of COVID-19 emergency grant funding that the legislature authorized. The first $50 million under a different grant fund, the short-term emergency fund, was awarded back in early April, on April 8th, to about 350 provider organizations around the state. So the legislature's support for these efforts has been critical to help providers all around Minnesota, and we're very grateful for that. With that, I will turn it over to Chris Erisman. Thanks, Chris.
Thank you, Commissioner. Over the weekend, we saw a jump in ICU bed use, and I'd like to provide a bit of context for that. We had our largest single-day increase of 41 for COVID-specific ICU bed use from Sunday to Monday. The next highest one-day increase was 25 back on May 16th. We're also hearing of hospitals that were at or near ICU capacity at the end of last week. In addition, we have heard of isolated staffing concerns. This level of ICU use has not been unexpected. We track COVID-specific admissions as well as overall hospital, medical, surgical, ICU, and ventilator availability. This past weekend, the overall picture for ICU bed availability on May 25th showed 87% of the ICU beds in the metro were in use. Other regions of the state had more availability. For comparison, it isn't unusual for ICU beds to be 95% full during flu season. That said, we are keeping a close eye on this, and we are in regular contact with hospital leadership to address issues as they arise. And with that, I will turn things back over to Mike Schomer.
Thank you, Chris. We'll open it up for questions now. As always, we ask that reporters limit their questions to one primary and one follow-up so we can get to as many as possible. With that, operator, we're ready to take questions.
At this time, I'd like to remind everyone, in order to ask a question, press star, then the number 1 on your telephone keypad. Again, that is star, then the number 1 on your telephone keypad. We'll pause for just a moment to compile the Q&A roster. We have our first question coming from the line of David Ulrich with Pioneer Press. Your line is open.
Hi, thank you. We've just finished the Memorial Day weekend, and I want to talk just a little bit about the University of Minnesota model because this cuts to the heart of people's confidence in you guys and Governor Walz, because this is an important model. The last projections that were a couple of weeks ago suggested that the case number, the deaths could more than double by Memorial Day, and I'll spare all the numbers, but suffice it to say that we are not anywhere near on track with the 1,400 to 2,000 deaths by the end of May that that was the range that model had predicted, and I'm wondering if one of you guys can talk about that.
Sure. I think, that's a perfectly reasonable question. And as we have said from the beginning, the model is one input, one set of data that we look at, but it is far from the only one. And I think we've said it is broadly directional, not intended to be specific with its projections about numbers, either numbers of cases or numbers of deaths or specific dates, but with very broad ranges. That said, it is certainly the case that the projections are in the model. The scenarios that the model looks at are, so far, our actual experience is more favorable or more conservative than that. And so I think that is why periodically, you might remember the university team and Stefan Gildemeister talking about fitting the curve to actual data. And each time they do that, it narrows the range of future model, the range around the different projections. So I think it's perfectly fair. And to be honest, I think most of the models out there have seen fairly large-scale corrections, if you will, in one direction or another. The IHME model has gone the other direction. Their projections have become less optimistic as time has gone on, and many of the other models, including some of the data that we know others are using here in Minnesota, have become relatively more optimistic. So that's just a very long-winded way of saying I think this is not unexpected, and it's good news that we'd certainly rather have the model be not overly optimistic, but get more precise as time goes on with more Minnesota data. But again, I just would reinforce people shouldn't think that the model is what is determining the governor's policy decisions, because it's really not. What it did in the beginning was clearly help us understand and quantify the degree to which more ICU capacity was important for minimizing mortality and long-term negative health outcomes. And so that's where we put a lot of focus, and I think that's where the model can be useful, is pointing out what are the things that most influence these broad directional outcomes so that we can work on those.
Just very quickly, closer related, since we've gone the other way, our doubling rate keeps slowing. Do you worry that there's a growing sense out there that all of this coronavirus stuff is just simply a little overblown?
I think that is something that we've talked about early on, and we continue to talk about and be very, very aware of, is that particularly perhaps among people who don't know anyone yet, and I stress yet, who's been directly personally affected by COVID or had a severe bout of illness or even have lost loved ones to this disease. Folks might think, well, this is only a problem in air quotes for certain populations, but not for me, and that's just not the case. We've talked a lot about the role of the degree of community spread that we have around the state, that a lot of people, and what we've learned since the beginning of the epidemic about the role of asymptomatic spreading, that some of us may actually be carrying the virus, not have either very subtle symptoms or no symptoms at all, but still be capable of spreading the virus, and we are spreading the virus. The healthcare workers who then are taking it into healthcare settings or others. The food processing plant outbreaks that we've seen in now 9 counties, might be 10, Chris can comment on that, those too are having an impact on community spread, not in those counties, as people move around the state, and workers may work in one community during the week and go home to their families over the weekend. And we do believe, and again, Chris can say more about this, that all of these things that we think are isolated, isolated cases actually are driving community spread as well.
Thank you.
We have our next question from Theodore Keith with Fox 9 News. Your line is open.
Hi, Commissioner. Today we have two of the state's four biggest cities, Minneapolis and Bloomington, releasing guidance on how their restaurants can expand into parking lots, sidewalks, and other spaces to do this outdoor dining on June 1st. As these restaurant owners are renting their tables and chairs and tents and planning live music, they might be wondering, gosh, how long is this going to go on? How long are we going to have this set up outside and not inside? What is your guidance to them as far as what they should be thinking?
Well, I think when the governor talked about the next stages beyond June 1st, he didn't set dates for a reason, because we consider that we're in a pretty volatile phase in the curve, we think, with these numbers going up and down and hospital capacity seeming to beginning to accelerate. We really feel we need to keep a very close eye on the data. We also need to do a better job, I think, of helping people understand that it takes, probably 14 days plus, 14 to 21 days for something that is already in the pipeline to show up in healthcare utilization data or confirmed tests. So we won't know for a bit yet what are the results of the policy changes that have or the guidance changes that have already been made, both through executive order and the guidance. So I know that's not a satisfying answer. People would like to know a date certain, and honestly, I think we would be doing a disservice to give a date certain and then either have to proceed despite any warning signs. We talked about the dial-back criteria, that we're going to be monitoring really closely. So I think one thing that we don't want to do is say, no matter what those indicators say, we're going ahead on X date because we said we would. That said, we totally understand that people need something to plan toward. So that's why the folks continue to work on guidance for kind of best practice protocols that need to be in place when we do go to those next phases. And I just understand how frustrating that is, but I think we need to see, what the data reveals about the impact, especially on community spread and hospital capacity of the things that we've done more recently.
May I just ask, Commissioner, on June 1st, will you be planning to eat in a restaurant parking lot or on a restaurant sidewalk?
That's a great question. And, yes, I absolutely will be comfortable doing that, especially if and I will be sure to know and sure to ask what the practices are that the restaurant has in place. If the distancing is clearly right and the maximum capacity is manageable and folks are wearing masks and my companions are wearing masks, then yes, I would.
This has been a WDIO News Special Report.